from the moment you receive it, you need to administer it within 4 hours. If you do not administer it within that time, you need to return this blood. Okay. Now you're going to check this blood. Make sure it looks like blood. Make sure you have the right blood. You're going to check to see, does that blood, number one, does it look the color it should look? Is it red blood cells? Does it look red? If it's red, if it's RBCs and it looks green, we got issues. There shouldn't be clots. There shouldn't be pus. There shouldn't be anything that's abnormal in it. There should not be air or bubbles in it as well. Okay. Now, when you hang this blood transfusion, you have to hang just normal saline, nothing else, to administer this, to kind of flush it down. Okay, so what else are we looking at? Make sure two licensed individuals are checking. You're checking the cross-match number, patient's name, identification, the type of blood, right? The type of blood, make sure that's matching, right? Before the transfusion, you need a vital sign, 15 minutes during the transfusion and 1 hour after. Okay, so when we do check those things, make sure that we are noting down this, if the patient is having a transfusion reaction. What is that going to look like? Transfusion reaction is basically the same thing as your allergic reactions. So airway closing, fever, itching, hives, you're stopping this transfusion. What do you do when you stop it? You stop it and you flush it with normal saline and you disconnect. Okay, you want to make sure to flush that. You don't want that staying in the system. Okay, now you're going to call your doctor, and most of the time you're going to give medications. Two medications you give: Tylenol for the fever, diphenhydramine or Benadryl is another name for it, for the allergic reaction. Okay, but those are your steps there. Okay, bone marrow suppression. So when we talk about bone marrow suppression, usually we link it to chemotherapy and radiations, things that suppresses the bone marrow. So what does the bone marrow do? Let's keep it simple here. It produces 3 types of blood: red blood cell, white blood cell, platelet. If you remember anatomy, you should be fine with bone marrow suppression. What does red blood cell do? Deliver oxygen. What does white blood cell do? Immunity. What does platelet do? Clot. If you are missing those 3 or low on those 3, anemic, leukopenic, thrombocytopenic, those are the terms for those 3 being down. Anemic, you're going to be fatigued, pallor, right? Weak, because there's no oxygen. Leukopenic, you're going to be what? A lot more sick. Your immune system is low. And then thrombocytopenic, you're going to be bleeding. So note down all the signs of bleeding: petechiae, bruising, GI bleed, emesis, melena, that's dark tarry stool, that's the term for that. Those are things you're noting down for. But that is the main side effect of chemotherapy, is bone marrow suppression. Okay. So next topic, bronchoscopy. So when it comes to bronchoscopy, you have to be specially trained to even assist with this. What is the job of the LVN? So what is the job of the nurse in general? Number one is you're going to be prepping the patient. You're going to make sure the patient is properly prepped for the procedure. So biggest, most important thing for bronchoscopy is they have to be NPO 6 to 12 hours. Why? Because we don't want them aspirating on the table and then it going the wrong way, right? That's for any general surgery. I just want you to keep that in mind. These are the hours you need to note for how long they need to be NPO. And then post-procedure, you're noting down vital signs, O2 stat, and then respiratory status, because they have been sedated. Okay, burns, partial thickness. I know I just said partial thickness here, but we have 4 degrees of burns, right? We have your first degree, which is just a sunburn, second and third degree, which is your partial thickness, and then the 4th degree is full thickness. So whenever you hear partial thickness, it's second and third degree. So superficial is just a sunburn, the upper epidermis. Second and third degree is going to be between the epidermis, dermal layer, and almost in the subcutaneous layer. Those are your second and third degrees. 4th degree is to the bone and muscle, just like your pressure injuries. They kind of have this same type of staging there. Okay, CPR hand placement. The biggest thing to note down with this one is, please don't just rely on nipple line. People have anatomically different nipple lines. So what I want you to note down is that chest plate, that sternum, the middle of your chest plate. You're going to go bottom half of that sternum. So find someone's sternum and go bottom half. That is where you're placing your palm. Right? That is your CPR hand placement. All right, chronic kidney disease. Let's keep it simple here, because if we go in depth with chronic kidney, there's so much to talk about. But let's look at what the kidney does. Chronic kidney what filters out water, sodium, potassium, right? And a couple of things more, but let's focus on those main three things. So if you have chronic kidney disease where you are not expelling that, what's going to happen? Your lab values are going to skyrocket. Mainly here, potassium, right? We talk about your Lasix. When you pee out a lot, you pee out the potassium. Think of it as reverse with chronic kidney. You're not peeing, you're holding on potassium. So you're watching out for signs of hyperkalemia. So when you note down signs of hyperkalemia, note down what your potassium is for. So main job of your potassium is going to be for cardiac rhythms and muscle impulses, right? So if you don't have that, right, muscle weakness in general, but the main thing you're watching out for, if that's too high, you have muscle weakness, and what you're watching out for is the heart, right? High potassium can cause cardiac dysrhythmias, and worst of all, it can cause a cardiac arrest. So I put down your CBCs, your lab values right here. Please know your lab values. Can't stress this enough. We talked about your hemoglobin and hematocrit, right? But know your other lab values as well. As well as your electrolytes. These are the most commonly asked electrolytes, which belongs to your basic metabolic panel. Know these. These are very, very important. I gave you guys a tip on when you take your NCLEX and HESI, when you get that piece of paper and the exam starts, if electrolytes and lab values are your weak points, that's what you regurgitate. Regurgitate that information at the start so that when you get a lab value question, you don't have to kind of rattle your brain and you're wasting time trying to think about it. Okay, CAS care. CAS care comes, when you do CAS care, it's all about the do's and don'ts, right? Let's talk about the do's, right? Let's talk about the do's. Do not get it wet, right? You want to elevate it so it doesn't swell. Rest, ice, compression, elevation. Same thing applies here, right? And basically, you don't want to hold it with the tips of your fingertips when it's drying. You want to hold it with the palm of your hand so it doesn't create those finger creases. What do we not do? Do not stick anything inside it, especially when it's itching. That's what you teach them. Don't put powders, lotions, no application of anything. Don't cut it. Don't take it off yourself. All right. And most importantly, what you're going to watch out for is the skin. So the edge of that cast, you're going to want to apply what we call pedaling. That's the technique used to prevent skin breakdown in those areas. Chemotherapy side effects, we talked about the bone marrow suppression, so I want you to refer back to that, but let's add some stuff here. Chemotherapy, what does it attack? It attacks the most fast-growing cells in the body. So think about everything that's fast-growing on you that heals very fast. Hair, right? You cut your hair, it grows back. Your nails, you get a cut on your lip, it heals fast. Your GI system, right? Those things heal fast. So those things are getting attacked. So hair loss, because it's growing fast, is getting attacked. Nausea, vomiting, because it's your GI system, right? Your skin in general is fast growing. It heals pretty quickly. So changes in those areas. So those, if you have trouble remembering what side effects are, know what chemotherapy attacks, and those are the areas you'll have side effects. Okay, CVA, cerebral vascular accident, or in short, a stroke, a clot in the brain, or a hemorrhage in the brain. We haven't talked about much with stroke yet, but note down the most common things you want to know for a stroke, and that is be fast. There's loss of balance. There is pupillary changes, which is your eyes, B-E, eyes, your perla. Check your perla, right? Fast, face is your F. That is one side of the face is going to be drooping. Arms, you ask them to raise their hands up. One's a little lower, one's a little weaker, right? Speech, they have what? Word salad. Speech doesn't make sense. They can't speak at all. Those are your signs. And time is brain. The faster we get them help, the more brain cells we save. All right, colostomies. When we look at the colostomies, let's just talk about the stoma here. And it's nicely loaded down in this picture. It should be red, moist, and painless. So anything outside of this, you are going to alert your physician. Why? So you're going to alert them on anything dusky, pale, gray, brown, black, right? Painful and dry. You are alerting them on all of that. Why? Because something's wrong with the perfusion at that area. And if this becomes necrotic, we have some problems there, right? Okay, esophageal varices. So if you have trouble remembering this, think about your varicose veins in the legs for those that you've seen patients with those. Those are the same things that are happening in your esophagus. And whenever those happen, that's just an increase in pressure. So let's take a look at what causes that. So esophageal varices, if you take a look at your GI system, right? It goes into vessels, it goes into veins that go to the liver. So your GI system, it absorbs food, goes into vessels, goes to your liver. From the liver, it goes, basically from the liver, it goes to your bloodstream. Now, your GI system connects to your esophagus. So if something's wrong with the liver, meaning cirrhosis, fluid or blood volume or whatever is backing up into those vessels, causing the varices in your esophagus. Now, what's the problem with the varices in your esophagus? You see how swollen they are? At any time, they can bleed out. Bleeding is your number one issue. Especially if you eat something, it grazes and nicks that area. Bleeding is your number one issue. So what are we watching out for? Number one, we're watching out for coffee ground emesis. If they start throwing up, it's coffee ground. We got to watch out for a bleed. If they're excessively swallowing, that means it's a little higher and they keep swallowing that blood. We got to watch out for those two, okay? So those are things to watch out for. I put the complications down here as well. So diabetes, gangrene toes, you guys know that. Okay, DM, hyperglycemia with diabetes. So whenever we talk about hyperglycemia, with diabetes type 2 or type 1, you have two problems. Hyperglycemia, hypoglycemia. With hypoglycemia, that's going to kill you right away. Hyperglycemia, it's a much longer route. But we got to note down some symptoms that come with hyperglycemia when it becomes a little bit more chronic. The 3 P's, polydipsia, polyuria, polyphagia. Okay, remember those 3. Keep that in mind. Those are the classic signs. Polydipsia, you're thirsty. Polyphagia, you're hungry. And polyuria, you're peeing a lot. Okay, the big 3 signs. And of course, complications of diabetes in long term is what we call retinopathy. So that's plaque buildup or plaque buildup in your vessels of your eye because of the diabetes. When that happens, people tend to lose their vision changes. So there's going to be something that happens with how in their sense of sight. So you want to note down any changes in vision when it comes to your chronically diabetic patient. Now, let's talk about the endpoint, the complications of this. Diabetic ketoacidosis. Usually a problem with type 1 diabetics. Whenever we have diabetic ketoacidosis, it's when their blood sugar has been way too high that it's causing certain issues. And we're developing ketones, which is a waste of acid, right? Ketones. So the biggest difference you're going to see other than the high blood sugar is we have ketones in the urine. Okay, we're going to be noting down that the ketones are in the urine. Classic signs, we have what we call Kussmaul's respirations. It's a certain way of them breathing, but also they have a fruity breath odor, because that's the ketones. They're breathing out the ketones. Blood sugar is usually above 240, right? Blood sugar is usually above 240, and their potassium's still a little high. And they're peeing, the 3 P's, polydipsia, polyuria, polyphagia. So what do we need to do for this patient? Again, ABCs, right? We're going to deal with the ABCs. Because the fluid is our biggest problem, we need to hydrate, give insulin, and replace electrolytes in that order, right? Right here. Hydrate, insulin, electrolyte replacement. Now, certain causes to this for your type 1 diabetics, anything can cause this. When they're sick, when they have an infection, they can go into DKA. When they stop taking their insulin, they can go to DKA. So those are things you want to teach them to watch out for. Okay, dehydration. Know your signs of dehydration. When you check skin turgor, know what that's called. That's called tenting, right? Check it either back of the forearm or the clavicle. Then epididymitis. When you look at a scrotum right here, epididymitis. The epididymis is just that area where sperm is stored. So whenever there's an infection, that is the area that's inflamed. Epididymitis. So what does that look like? Testicles are swollen. There's a fever, right? There's inflammation. So those are things you got to watch out for. It's ultimately a bacteria, so we got to get antibiotics. All right, let's talk about fluid volume excess and fluid volume deficit. We'll start with the excess, too much fluid.